Thank you very much for having me, everyone. To start with a slight apology, my brief for this talk was actually talking about the role of the nurse more than actual specific side effects. So I really hope I don't disappoint. But I do feel it's really important to talk to you all about the role of the nurse and what contribution that we can give towards your care. Okay. But what I'd like to do first, because I know we're international, is I understand obviously in the UK we have the clinical nurse specialists, but just wondered, like a show of hands, does anybody else have a sort of specialist nurse or a key nurse that they can identify with their disease? You do in Canada, yeah.
So in your countries, is there a similar role in the treatment centres where you are, where there is a specialist nurse who is specialist in your disease? Can anybody else say that?
No, okay.
Maybe one or two people are putting their hands up? In the US, maybe, yeah. Okay.
Okay, well, hopefully I can give you a little bit of insight into the sort of advanced role of the nurse and how we're moving on a little bit in the UK. Before I start, I wanted to just go back a little bit in nursing. I'll just see if I can get this right. Yes. This is Dorothy Alice Watson. This was taken in about the 1930s. A few years later, she got married and became Dorothy Francis, my grandmother, bless her. Now, in the 1930s, as a nurse, when she trained, and she's still a student nurse, whoops, oh, and you can see that because she hasn't got her cuffs. So as they get promoted, they're allowed to have cuffs to roll their sleeves up in those days. But basically, my nana was taught how to do dressings, how to feed patients, how to follow the doctor's orders, how to sterilise implements and assist in theatre. And that was pretty much the role of the nurse back in the 30s. You were very much the doctor's assistants and you were very much mopping the fevered brow. We still mop the fevered brow, by the way. We still do, I promise you. And we're not too posh to wash either. So these days, when I started training in the 1990s, the word advocacy was weaved all the way through the training. We were taught from a very early stages that we were, as nurses, the patient's advocate. We were the voice of the patients, and it was down to the nurses to stand up for the patients and look out for the patients. And you'll find in these days, in a lot of the Nursing Council's codes of conducts and ethics, that it's mentioned. And in the UK Nursing and Midwifery Council, it clearly states that the nurse is the patient's advocate. And it is our responsibility to ensure that the patient is getting the best health that is out there, ensuring that they've got the best access to resources and they have the best treatment, and that we help them in their decision-making process. So all along, they're saying it's really down to us to make sure that we are there for you. Okay, and you can say also we've got the International Council of Nurses and the American Nurses Association as well, and I'm sure it's probably the same across the world. There's different components of a patient advocacy in nursing, and the first one is all about obviously developing the relationships with the patients, and that's really important. We're looking at their interests and well-being, not the centres, not the conditions, and not actually really the families. And an example of this is I sat in clinic the other day with a patient, and it was, shall I have hydroxycarbamide or shall I have interferon? And you've got the patient's family wants the patient to have interferon, but he doesn't. He's terrified of needles. He would rather go with hydroxycarbamide, and for various reasons, but also he felt that by taking it daily, he was less likely to forget it. The side effect profile, he was working every day. You know, what's more important, what the family want or what the patient wants? You know, and it was down to me to sit there and try and sort of weave it out and help the patient make their choice. Okay. Second, respecting and valuing the patient's freedom. Okay. Really important, again, as Prof will agree with me, we actually have quite a lot of patients that don't want any treatment. They really don't want to start on that hydroxycarbamide or their interferon. They would rather we adopted a watch and wait. We can't actually pin them down and put tablets down their throat. It's entirely up to them. But what we have to do is basically make sure that we've given them as much information so that they can completely understand the decision that they're making. Okay. And also then it's about sharing decision information with the patients and ensuring that we're empowering you to make those decisions, again, based on the most information that you can possibly have. In general, there's a lot of nurses that have contributions to MPNs. This is our team in the Haematology Day Unit. so our outpatient treatment area. And I've just put a picture up there just to say that it's not just about the clinical nurse specialists, and aren't we great? Behind the scenes, there's a lot of other nurses that we also liaise with that would help, based from our healthcare assistants, who are our non-trained nurses. This is John here. He's highly specialised in venesections. He's amazing with venesections. So he knows a lot of our patients. He's got that relationship with them. He's very good. Down to all the qualified nurses, and obviously our sister here, Rosie, who manages the day unit. But we also have our research nurses. We've got a massive research team that also works. But then if you go out into the community, we've got our district nurses. We've got our GP nurses that also help. They'll go and see our patients. And we liaise a lot with those, especially if our patients are older, they can't make it into the hospital. The practice nurses are GP nurses. And then you've got the transplant side of things, as we've just heard, but also we've got the end-of-life nurses as well, who again we'll liaise with quite heavily. So it's not just about me and the specialist nursing role. There's a lot of us out there that are contributing towards the care. Focusing a little bit more closely onto the CNS, there are actually two of us. My colleague Claire Woodley is not here today, but we are a little bit referred to as Tweedledum and Tweedledee, for those of you who know about Alice in Wonderland. So there are two of us that work together. But I've put this picture in of some members of our extended team because it's not, as I said, just about the CNSs. We work as a team. We work individually on our own, but within the actual MPN team. Okay, so these are other members of our team. A specialist nurse, by definition in the UK, is basically a nurse that works at an extended role. The nurse typically has specialist skills and expertise in their clinical area, and we've usually gone on and done a higher level of education as well. And I've broken down the way that I see our role as the MPN CNSs into various different aspects, which I'm going to go through separately, but basically we are a key worker. We treat and manage the patient's health needs. We advise and we inform patients. We provide physical, mental and social support, promote the health and well-being of the patient, but we also are educators as well. So the key worker. We come under the cancer umbrella, and in the cancer world in the UK, all patients are entitled to have a key worker, and the key worker is the nurse, and it's the specialist nurse, and they are the point of contact for the patient throughout their whole so-called disease pathway. So we are supposed to be there the day that they're diagnosed. We're supposed to be there with them throughout their treatment, or the day that they have treatment, or when they are considering treatment as well. We're there at any changes in their condition or their treatment, and we're also there for end of life for them as well, and at any other stage that they request. So the whole idea is we are the one person that is consistent all the way through their disease pathway, and we should be accessible and easy to contact throughout the whole of this. It's not very easy to ring up a hospital and contact your doctor and ask them about side effects or about this test, or I'm not sure if I can do this, can I have this vaccination? This is where the key worker comes in. But we are also supposed to be coordinating the patient's care pathway. So, for example, for us, it would be an example would be, right, okay, well, we need to bring you back for a marrow, but we also need to get this test done. Let's see if we can do it all on the same day. I'll tell you what we'll do is we'll just see you a little bit out of clinic just to get this done because it'll be easier, and then we'll have that test ready for that day. But also interlink with other specialists and healthcare professionals just to try and bring it all together and streamline the experience. I can see John nodding. I'm clearly getting some of it right.
It works.
So we treat and manage health needs. So myself and my colleague Claire, we've basically done some extended training. So we have clinical assessment skills, and I'm also an independent nurse prescriber, so I can be prescribing your medications. So we work two ways in the clinic. Within the clinic, we have the clinic with the consultant. There's usually a registrar, and then one of us nurses will also be clinically reviewing patients. So we'll be taking the patients off the pile, taking in the room and doing the medical assessment and also dictating their treatment. And the other nurse will be working as a key worker. So basically, you will see us instead of seeing a doctor within the clinic. You don't have to. You can see the doctor as well if you want. It's absolutely fine either way. But we do actually have our own little list of patients that actually prefer to see the nurses. And you tend to get a little bit longer with us as well, in all honesty. And I do find that I will sit in a consult with Prof and a patient, and when I take them away to another room, I'll get a slightly different side of the story than that, yes, doctor, no, doctor, of course I'm doing this, doctor. So we can sometimes wheedle out a little bit more truth from the patients. And patients actually feel they can talk to us a little bit more free sometimes as well. Not all the times, but sometimes. Okay. We also run nurse-led clinics. I have a specialist interest in venesections because I'm a vampire. So I actually run a nurse-led venesection clinic, so I will see the PV patients that we venesect alongside other conditions as well. And we've done that because obviously you come to a massive haematology clinic, you sit there, you wait, and then you have to wait and go and be venesected as well. And a lot of these patients have been coming for years. John's quite right, I have been around for many years, since 2000, and I started as a junior nurse in the day unit venesecting people, and I still know some of those patients. I still see them today, so it's great because I get a really very good relationship with people, and I absolutely love that. And they come through my clinic, they don't go to the consultant clinic, they come up, they're seen quite quickly, they go through, they have their venesections. The whole thing is a lot quicker. A lot of people work, they have a life, they do not want to spend their whole day in hospital waiting. So by taking people out and putting them in the nurse-led clinics, that we can get through a lot quicker for them. Okay. We also have a nurse-led telephone clinic as well. So again, if people are really busy, they can have their full blood count taken, they can go to work, we'll have the results, and we will ring them and do the consult down the phone. Now, the deal with the telephone clinic is that you do have to come to clinic a minimum of once a year. And the minute that we pick up there's something not quite right, then you will be thrown back into the main clinic faster than you can walk. So we are very, very careful with that. But it works very well for our older population and our working patient who are very much watch and wait, or our young ET patients that are very well. And it really means that, again, people can get on with their lives. Okay. We also deal with a lot of what we call SOS calls, people ringing up, I've got a tingly big finger, or I've got a really swollen calf, I don't know what to do, my headaches are getting worse, I think my bloods are getting a bit, thing. So, and we'll bring them into the day unit, do their bloods, we'll assess them and make decisions about how we're going to treat them. And we'll do that out of clinic via the day unit. But we will also divert to A&E if we feel appropriate as well. Education, advice and information, we're obviously there. Now, we do quite often start at the very basics with people. There's no point telling them that they've got a blood condition if they don't even know what the blood does. So it's down to us really to work out how much does this person understand? How much do they want to know? And where do we start? Okay, so we will quite often start at the very basics and work our way up. And this might take quite a long time. It won't take one day. But in order to make sure that people understand that the most that they can and that they're able to about their condition, then, it's for us to start at the background and work with them. It's really important that we pitch this right and that we get to the right level for each patient. Not everybody wants a scientific paper. Some people just want to know they've got red cells, white cells and platelets, and they might have a bit too many of them. So it's very, it's very down for us to be able to sit there, gauge the patient, get to know them over a long period of time and work out exactly where we come into them. And this is all about empowerment and advocacy and just making sure we're getting it right for them. We also back it up with all our information as well, so nobody goes home without anything written. Quite a lot of it. And there's John. We give a lot of information about drugs, a lot, and also about, obviously, the side effects. We will really help the patient make their decisions about the treatment. This is Prof's slide that I have stolen. And it's so important that we get it right. Not everybody wants what we are trying to recommend for them. People you have to live with these conditions, not let the conditions rule your life. And therefore, it's very important that you make the right decisions for yourself. Okay. Again, we also manage the venesections a lot, and we will talk people through the venesections. They're not small needles. It's terrifying. To be honest, you'd have to catch me before you could stick a needle that size in me. So I understand. It is what it is. But we're there to try and sort of help you through it and talk you through it. We will obviously educate people with the interferons. We'll teach them to give the injections. And if they don't want to give the injections, they don't have to. We can book them to come into the day unit once a week until they're comfortable doing it themselves. So we're not saying, here's a needle, off you go, do it. I can tell you now, from experience, within a couple of months of having to come up to the day unit and waiting about an hour to be given an injection, most people get it and do it themselves. But, we offer that for them. And we also, the week after they start on their medication, whatever it is, we will ring them at home. So we don't bring them up, but we'll ring them. Are you okay? Is there any problems? Do you have anything that you want to discuss? So we give them that opportunity again, and that sort of that security to be able to have a chat with us and make sure that everything's okay. Instead of just giving them these tablets, say, by the way, it's hydroxychloroquine. Yes, it's chemotherapy, but you'll be fine. Come back in a few weeks. We really try and make sure that people are okay. If they're feeling a bit sick, we can help them with that. We can tweak it. It's not a problem. We'll signpost people to the right direction. If they want any other advice and tips, can I fly? Do I need insurance? Can I have a letter to go with me? Can I have vaccinations? All that kind of stuff. We're very happy to, help with the information. We liaise with other healthcare teams, quite often getting emails, I need to have my tooth taken out, should I stop my aspirin? What about my hydroxycarbamide? I'm going to have a hip replacement, my platelet count's 800, what shall I do about it? Blah, blah, blah. So, and, we are there to try and liaise, either pull in one of the doctors and just say, right, okay, let's work this out as a team, or advise stop your aspirin 7 days in advance. So we are there as the link between the MPN condition and everything else, because we're all humans and we don't just have an MPN. We all have other conditions. We'll give financial advice as well. And then there's the physical and mental side of this. We are seeing more and more and more people struggling with their diagnosis, be it a very young patient with ET up to an older person. The cancer word doesn't help. It has a massive impact. And it's really important that, yes, this is classed as a cancer, but it can be quite a low-grade cancer. And we really are having to go back to patients time and time again just to help them to adjust to this and get used to this condition. You come into hospital with a blood condition and you walk out the door with a cancer. But I look all right. I feel fine. What's going on here? And it takes a long time to try and work it out in your head. And we have a team of excellent clinical psychologists who we will also liaise with, just to help people manage their thoughts and their feelings around this disease. And again, it's very much about learning to live with this chronic disease and not letting it rule your life. Yes, I've got it. I have. But do you know what? Still go to work, I've still got 2 young kids, I still want to jump out of the aeroplane or whatever. We might advise you don't do that, but, we try very hard to work with you. We liaise with work if needed. If people really struggle with work, we might advise that you cut down on your hours, and we're very happy to be behind the scenes and help support people with these conditions. And also help them make decisions. What am I going to tell my family? I mean, do I tell my children? Do they need to see my injections? If they don't see where am I going to put them? What am I going to do? But if I tell them I've got a cancer and actually Daddy's fine, what do I do? So we really try and work with them and help them talk through all these thoughts and feelings. Wow, if I had £1 for every time I gave a health education talk, I'd be so rich, so rich. It's not even. I'd still be here, obviously, but obviously alcohol, smoking, eating healthy. I mean, need I go there? One of the biggest things that I say to people is, this is a partnership. This is a partnership between us and you. I can do my bit. I can help educate you. I can give you all the information you need on your condition. I can help you make treatment conditions. But you have to keep yourself well as well, and that is your part of the bargain. And I can't control that. I can't, again, stop you from drinking and smoking and everything else. But, in order for you to optimise your health, you have to help us. And it's a two-way partnership here. I'm very happy for us to continue doing our stuff in the hospital. But, if you choose not to do that side of thing, that's up to you. I can't, but we would advise that you do this. Okay. Again, education, it's just going back to this. And just to say that we have a whole host of written information that we give out. We give out a new patient information pack when people come to us and first diagnosed. And I do like to give them our British Heart Foundation information as well. And then usually some information on diet. We're very lucky we have a fatigue workshop run by our cancer physios at Guy's that we send a lot of our patients to as well. So we're very lucky we have access to a whole host of resources. But not only that, we also educate our colleagues as well. So, we will go into the day unit, teach our day unit junior nurses. My grandmother's not in that picture, by the way. I just liked it. But also we will educate other nurses as well. So we quite often have other nurses who want to take on the extended MPN role come in to shadow myself and Claire, my colleague Claire, nurse, in the clinic as well. And we also have a national Association for Myeloid Nurses as well and practitioners, and we're actually setting up a website now because it's so difficult to get nurses in a room together to try and educate them. Last year we did have a national nurses education day, and it was amazing and it was brilliant, but actually it's becoming more and more hard for nurses to get the time off work to attend all these different educational sessions. So we've now decided that actually we're going to take it to there, and we're going to have a website, and we're going to try and educate the nurses through the website. It will make life easier. So it's not just about shouting out the cause to the patients, but it's also very much about talking to the nurse. This is my son. Number one, just to say that the UK do have nice beaches. Thank you very much. But also, we like to fly the flag at any occasion. I showed this to John, didn't I? Yeah. So just to go back, I have very briefly touched on a whole host of aspects that the specialist nurse can contribute towards your care as an MPN patient, and how we can help sort of empower you to manage your own condition. I do apologise that there wasn't a side effect. It wasn't a talk on side effects. There was an error there. And I think the really important thing is it doesn't matter what kind of nurse you come across in your hospitals, but I think it's really important that all these nurses should really be out there and helping to advocate for you. Thank you very much.